listening to the Pharmacy Podcast Network.
This is the Pain Pod.
You want to see pain? Look at these.
Welcome to the Pain Pod, the podcast for all things pain management. Hosted by the Pain Guy, Dr. Mark Garofoli. We'll be collaborating with numerous pain management experts, talking about substance usage disorders, the latest treatment modalities, and most important, focusing on the pain of our patients as leading providers of pain care. And now, here's our host, a man wanted in all 50 states, a suburban city-like mountain man,
Without the beard.
from the hills of West Virginia, and certified in weapons of mass destruction response. It's Dr. Mark Garofoli.
All right, welcome back, Pain Pod Nation. We've got a treat for everyone here today, of course. So it's not just yours truly yapping on the mic like sometimes. We have a guest again, and quite the illustrious, quite frankly. But big picture, what we're going to be talking about here today. I mean, after all, it is the Pain Pod. But, there's often those blurred lines of pain and substance use disorder, addiction, and, the roots. We're going to be getting back to the roots. Folks often talk about like the iceberg and seeing underneath it, or the weed, not cannabis, folks, just the stuff that grows in the spring, and the roots underneath there. Or sometimes the root is everything, like a carrot. We're going to go to perhaps those types of levels along the way. Keeping in mind in the background that, our drug crisis that's out there, claiming a lot of American lives across the globe too, but we usually concentrate on the American side. So I'm sure those of the many that have listened to previous episodes know that, an American dies currently every 6 minutes from a drug overdose, not particularly opioids, but drugs overall. Other side of the extremes, babies born dependent, not addicted to, but dependent to opioids specifically, about every half hour. That's the two extremes of life there. So that's a lot. But again, the point here today is getting to the core of it all. So that's where we just say hello, trauma. Right. So here today we have Helen Sairany with us. Who hasn't met her, right? She's traveled a darn near the whole country, state by state. I know it's not all 50, but might as well count it. Never know. Who hasn't met Helen, right? But so for those of us that haven't read all of her books, we've got Childhood Hang On, Trading Grenades for Candy, The We You Don't See, more recent one, or perhaps you haven't seen or heard any of her presentations yet. But Helen, give us some insight into Helen. What's your story? Of course, just an appetizer for the books and for everything else you have going on. But welcome to the Pain Pod, and what's up?
Thank you so much, Mark. Really excited to be here. So I am a fellow pharmacist like you guys are, but I took a little bit of an unconditional path in terms of my journey because of my background in trauma. I am clinically diagnosed with PTSD, and that's partly why I developed this passion for trauma. So after graduating from pharmacy school, I joined, the frontline heroes to serve the underserved at the front line for 3 years. And that is when the sad reality came to me, that I realized that I was struggling with a mental disability myself. But I did not fall for the label. The label was a bit difficult. And let's face it, Mark, back in 2013, when I was diagnosed, this whole mantra of it's okay not to be okay was nowhere, so mental health was, and it still does, but back then it carried a lot of stigma. And with me being like an overachiever and kind of getting out of pharmacy school and shooting for all these trainings, having that label was a bit devastating for me. So that's when I took upon myself to do more research and, take that more proactive role. And that has led me to become a trauma-informed pharmacist. I have served in a lot of administrative as well as leadership roles in the profession. So my area of trauma it is clinical for sure, but it's more administrative administrative. It's more personnel type of trauma, and it's more that childhood hang on, the childhood baggage that we all bring into the workforce. And unfortunately, a lot of us are not aware of the childhood trauma that we bring into the workplace, and that baggage becomes the workplace baggage. So I'm hoping that we can shed some light on this aspect of trauma, because there is a moment of reckoning in the profession in terms of pharmacists, walkouts, strikes, burnout being record high. And of course, the more you're burnt out, the more likely you are to misuse and abuse a substance or a compulsive behavior that negatively impacts your quality of life. So, like you said, I have a couple books, but I also try my best to go around the world, around the globe, to talk on this important topic. And I am excited to be launching my certificate training program for the National Mental Health Awareness Month, which is going to be May 1st, on everything trauma in the workforce. So really excited to be here and happy to answer any questions you might have related, to my line of work, as well as anything pertaining to trauma.
Well, thank you. Turns out I think we'll have a few for you. So I could really appreciate, everything, but a couple of the big picture things you were saying there of, just having like many a diverse, career pathway. And then, you brought up that label idea. We may come back to that later, right? Or maybe you would even, of just, how different strokes, different folks, people go about things differently of being one with what we have going on. I'm a huge proponent of we all have a story, and not everyone's privy to the story until you are. But it's really, really good. And I mean, hey, even I mess up. We're all human, of not remembering that for folks along the way. But you mentioned, as far as pharmacy career path, certainly you had, if there's a traditional path anymore, I think we're losing sight of what it actually is. But it's certainly a different path than, like, say, your average clinical pharmacist, or, working, whether it's community pharmacies, hospitals, so on and so forth. So a different path there. But if your career path in pharmacy never really pivoted, where do you think you would have ended up? Like, if you went one of the quote unquote traditional hospital, community, maybe even industry, where do you think you'd be?
I'm trying to think really hard, because I've been a state exec, I've been a community pharmacist, I've been an ambulatory care pharmacist. It is hard, honestly. It is hard, considering how much I've done in terms of things that are not necessarily related to the stuff that we are trained to do. But I would say, if I were to have the max impact, I would definitely consider academia. Academia in terms of, how I would emphasize more content related to personnel, related to adversity, related to our responses to the triggers in the world. And I feel like pharmacy school needs to do a lot more. We do such a great job in the clinical, as well as the administrative, maybe clinical far more than the administrative, but we tend to forget that, after all, this individual who's going to graduate with a licensure is a human. It's a human.
Right,
and I
right.
feel like we don't do enough of that human side, if that makes sense. I would say that's what I would root for if I were to
Awesome.
go
Well,
back.
hey, that's my main hat that I wear, so I can certainly appreciate that. Heck, as far as a background, I've had so many conversations with student pharmacists and various other learners too, of, picture being in the office and in the university, in the school of pharmacy, and thinking, like, I never had an intention of going and working in academia. It was the last thing I would ever, if I had to list 50 things, it would have been number 70. In fact, I didn't even keep my graduation regalia. Turns out you need that to get on stage as a faculty member, by the way, in any school. But you don't know. We just don't know. And then I appreciate you mentioning some of that diverse background too, and as far as career path for our student pharmacists, maybe new grads, and maybe those that have been practicing for 40 years listening, and other professions too, by the way, because it's most, if not all, schools of pharmacy have the proverbial P1, the first year experience of whether it's a career panel or a round table, or the big picture is realizing there's a lot out there. Everyone has, it's like a snowflake thing. There's not going to be one career that exactly mirrors the other, or at least it's very infrequent, of course, too. So All right.
Yeah.
So in your career, one of the major things I would think anyway is that, well, you seem to stumble upon becoming an incredible author. There's a lot of typed up words out there coming from you. But what would you say the world doesn't know about you?
Um, Gosh, doesn't know about me. I would say the passion that I have, for the profession, and I think a lot of you know pharmacists go into the profession because of this whole concept of making a difference, right? But I feel like in a way, our expertise, our talents, our knowledge, our passion has been limited to a metric. And when you are limited to a metric, Mark, you lose that compassion and fulfillment for the not only for your profession, but also for the people in your surrounding. And when you do that, you subconsciously retract not only from the profession and the sacred duty that you signed up for as a healthcare provider, but you also retract from each other. So the more we retract, the lonelier we've gotten, and the lonelier we've gotten, the more sick we've gotten as a society. And look at the record number statistics that you just mentioned with regards to addiction. Addiction is just one aspect of all the chronic conditions that is going on in the world. Now, one thing that people don't know about me is that I have a different perspective, a different appreciation of the medical profession after I got exposed to my line of work on trauma. Now, as much as I hate to say this, but I feel like in a way, after digging deep dive into the adverse childhood experiences study and my line of work on trauma, my training no longer became relevant to what I do because I perceive disease very differently from my training. I perceive
Hmm.
disease to be a manifestation of a life lived, a manifestation of a life lived. And unfortunately, the training that I was exposed to was more of like, well, what are we going to do? So I like to be more to be perceived as someone who is optimistic, as someone who is um, curious about what is going on, because I feel like that having that knee-jerk reaction about what are we going to do, what are we going to do, well, if 60% of Americans are having one chronic condition and they're on one medication, uh, it's it's hard to say, well, this is disease is idiopathic, or disease is genetic, or disease is a malaise. It is hard for me to believe that genetics has altered at such a fast pace over the years,
Hmm.
which you almost have no choice but to take a step back and think about, how did we get here? How did we get here?
Hmm.
So this is what I like for people to know about me. I've been thinking a lot about the state of the profession, and I think having a positive outlook will definitely change how we perceive things. But it is something that I don't share a lot about my training, as much as I love what I do as a pharmacist. But I would say my understanding of disease is completely different from what I was trained to do.
Interesting. And it's hey, I'm one of the first people to say you want as much diversity in the room, particularly people thinking differently. It's usually interesting when you get 10 people thinking differently and it's all over the place in a given room, but that's where the magic happens.
Yeah.
So all right, so
Yeah.
we've kind of been taking the appetizer and talking about pain, addiction,
Mhm.
all of that in the background here. But these days anyway, there's actually a mantra out there, and the DEA is actually taking it up. The Pain Pod Nation has heard it before: one pill can kill. Now,
Mhm.
some are certainly going to say, "Hey, that's like sensationalized doom and gloom." And then on the other side of the pill, pun intended, there's the stark reality that's talking about our illicit drug supply. And, the most recent DEA data says that when they seize, illegal pills, 7 out of 10 have enough fentanyl to kill someone, if not an
Yeah.
elephant, in them. So trying to give all sides of the coin as usual. So,
Yeah.
I, you know, behind that deadly curtain, though, that's the stories that each and every one of us carry. It's who we are. So, many times our stories involve, trauma.
Yeah.
You mentioned ACEs as well too. Can you talk about some of that overlap between trauma, pain, addiction, so on and
Yeah.
so forth?
So I perceive addiction to be a trauma response. Addiction is not a chronic disease. Again, that's another point where a lot of eyebrows will probably go up when they hear me say that.
I guarantee some just did. It's
Yeah, it is. I don't perceive it to be a genetic disorder. I don't perceive it to be a flaw in behavior whatsoever. I think if you really understand addiction, Mark, there is so much humanity about it. So much humanity. And I know before we went live, I was telling you how nobody wakes up one day saying, I am going to be an addict, or I am going to misuse XYZ and ruin my life. Nobody decides that. And let me tell you, regardless of how much DEA or any governmental institution decides to put rules and regulations, these people who are struggling with addiction, they know wholeheartedly what they're going through. They know wholeheartedly the consequences of the decisions they've made, right? But they have no choice. They have no choice because they know that state of numbness, it's far more effective than the demons of trauma that they have to live with. So what is addiction? I think addiction, it's a coping mechanism to trauma. It's a coping mechanism to trauma. So instead of asking why addiction, ask why pain. Right. What pain are they trying to numb with this substance or with this compulsive behavior or with this, I don't know what, because I don't like to limit addiction to just a substance. You know, we're all addicted to social media, to, screen time, to, gambling, sex, food. There are so many varieties of addiction, but unfortunately, society tends to kind of look just on the substance. I mean, look at the tobacco addiction, which is another devastating addiction that kills far more people than actual substances. But I would say a lot of time people get into a compulsive behavior they're not able to let go, or an addictive pattern that they're not able to let go. It's because they were trying to numb a pain. And living with that pain was excruciating for them. Excruciating for them. And according to the adverse childhood experiences study, those who have been exposed to adverse childhood experiences are more likely to misuse a substance. So it is a trauma response. It is something that people try to use as a coping response to get by. But then it started as an adaptive response, but then it turns maladaptive, and that is when it becomes an addictive pattern, if that makes sense.
Right.
But it always starts as a coping mechanism to a pain due to adverse childhood experiences, if that makes sense.
And that's I remember times when even coming up with, there's a product out there called cocaine. And I remember in various audiences saying, hey, why didn't we call it cope-cane? COPE, cane. Because that's a core of what, pick the substance, pick the activity. It's coping along the way. It's so fundamentally important. Like some of the things you were mentioning earlier of, understanding humanity. And it's, can one really understand truly humanity without understanding addiction? Now, understanding addiction isn't exactly easy, and there's lots of viewpoints, but it's a question that, it begs to be discussed at least. So, all right. So,
and
into
to get back
the trauma
to,
realm there.
Yeah, just to kind of get back to your question, can you understand humanity without addiction? I don't think so. Because, you emphasized story. Everybody has a story. And the stories that these individuals have to share, there is so much humanity about their life. And some of them get into this behavior because they thought they were making a difference. They thought they were trying to become better. There's so many stories involved. And let me tell you some of the stories that I've heard from individuals who have misused or abused. It is hard to judge. It is hard to limit such a component of a trauma response that involves so much humanity to a disease. So it's a very, very comprehensive, concept issue that I feel like only looking at it from a trauma response, from adverse childhood experience, that we could get anywhere closer to that humanity aspect of it, if that makes sense.
Very good and deep thoughts there. So, diving a little bit deeper here, we've talked about here today. I know it was even in your book, the we you don't see, understanding the long shadows of trauma. Really emphasizing that addiction, the roots within childhood trauma. So, maybe we skipped over some of the big picture things. Could you explain, as an expert, quite frankly, what is trauma? What's that relationship? I guess emphasizing that a little bit more with trauma and addiction.
So, the medical community or the mental health community likes to limit trauma to a big T and a little t. And I was just giving a talk to a group yesterday. You cannot limit the depth of human experience to a numeral or to a letter. So I don't like to focus to what SAMHSA is doing. I like to focus on the depth of human experience. A tragic experience might be a big T for Mark, but it might be a little T for Helen, right? So because we're the society would like to feed the concept of all of us being created equal, but let's face it, some of us are more equal than others, right? And that is where the concept of big T and little t is a little bit challenging for me to understand. Mm-hmm. So what I like to focus on is trauma is any event that is too much, that is too fast, and that is too soon for your brain to comprehend. Okay. Trauma is not about what happened to you. Trauma is what happens inside of you at a physiological level because of what happened to you. Because if we focus on the past, unfortunately, past is beyond anybody's control, right? I cannot undo war. I cannot undo tsunami. I cannot undo the pandemic. But let's face it, we all struggle because of the shock state that we were exposed to at a physiological level. And that's why I like to call trauma a psychological wound. That wound could be raw. When you're having a raw wound, you tend to be very inflexible because you're afraid any movement could expose that raw wound to triggers outside of you, which will cause you a lot of pain. So that's one version of the wound, the psychological wound. Or the psychological wound could be an old wound with a thick scar tissue. And we all know that scar tissue is nerveless, is not, it doesn't have emotions, it doesn't have sensitivity because it's so thick and it's trying to protect you. Now, in my honest opinion, the scar tissue, the old wound is far more dangerous than the raw wound, because when you're desensitized, it means you just don't care about what happens to you because you have been so damaged deep within. And that is the whole concept of desensitization or depersonalization that our colleagues in the profession are going through. They have disconnected from their body for so long because the conditions that they were exposed to was too much, too fast, too soon. And the only coping mechanism they had was develop that scar tissue. And what does that mean? It means they had to tune out of their body, tune out of their body to cope with the condition, right? But do that enough time, you become completely disconnected from your surrounding, from the sacred profession, from your patient, from yourself. And there are times where some providers tell me they are so preoccupied with the stress that a lot of time when they're home, they don't hear their child calling for them. You know what I mean? That is the scar tissue that I'm talking about, the desensitization. Trauma is also about good things not happening to us. Good things not happening to us. In the case of a child, when you're preoccupied because of workplace condition or because of whatever stress you're bringing into the household, that child doesn't have that mental capability or the physical capability to fight or flight to the condition that you're exposing that child to. Remember, children are very vulnerable. Okay, they're very vulnerable physically as well as mentally. So what they will do, they will freeze. They will freeze. Now, what does that mean? Freeze means they will tune out of their body to cope with the mental state that you are exposing them to. Do that enough time, that tuning out becomes a chronic adaptation to trauma, because again, the mental state you're exposing them to, it's very traumatic for them. So do that enough time, that tuning out translates to other classroom setting. And then the next thing happens, the teacher calls you, your child is having attention deficiency. They're daydreaming a lot in the classroom setting. Now, is ADHD a genetic disorder? It goes back to the same concept of addiction that we started off with. ADHD started as an adaptive response to a condition that was too much, too fast, too soon for the child to cope with, right? So 11% of children in the United States dealing with ADHD, genetics is a hard case to convince me with. I mean, that's a lot of kids in this country. And it's much higher in this country than other societies where community is a bit stronger, spirituality is a bit stronger, family structure is a bit stronger. So I feel like we're dealing a bit more with trauma, at least with what CDC is reporting, because of the coping responses, which is supposed to be natural, right? So trauma comes in a lot of formats, but I would say it is a psychological wound. It's about what happens inside of us because of what happened to us.
I really like what you talked about there with the wounds of like, when it's covered up and there was no nerves. It's this magical mesh between, our backgrounds and training as pharmacists universally, and then this relatively newer frontier or different way of looking at things that you articulate like no other. So that's it's all about the kiddos in the end, right? So here I go easy on you, but still not an easy one, I guess. So I'm asking as a dad. Happen to be a pharmacist too, I guess. Been called other things, but not going to ask about the birds and bees talk because, well, we're not there yet anyway. But any ideas on having the drug talk with kiddos out there? Any ideas? Floor is open.
So talking drug as in like substances, right?
Yeah, to use or not to use, or when you're in these scenarios, decisions, all
that. Listen, you can only have control over your family atmosphere, over your community, but peer pressure is real. And the important thing is for a child to be exposed to an emotionally mature adult. Why do I say that? Because a child between adulthood until they're 7, they don't have the neocortex, the prefrontal cortex developed, which means anything you feed to them, it goes into their mind unfiltered, because they don't have any rationality in the place to kind of reason, well, why is he telling me this, right? So that's why it's important that you talk to them. It's important that when they don't see mom okay, mom explains why she's not okay. Because they are so observant and they're very, very narcissistic. Now, I don't mean that narcissistic as in the narcissistic boss, the sociopath that you're dealing with at work. Narcissism in a child, it means they personalize everything. They want to feel significant. They want to feel like they're the center of attention. They want to feel like they're the most important thing in your life. That is a narcissism that I'm talking about. And they want to feel like they could be loved unconditionally. They cannot be loved because they did XYZ for you. Does that make sense? So that is unconditional love we're talking about. So between toddlerhood and 7 years old, you absolutely have to talk to them. Because chances are, if your family is functional, they might be exposed to some friends who grew up in a dysfunctional family. And what does a dysfunctionality involve? It means maybe there is an addiction in the family, or there is a mental health in the family, or there is a divorce in the family. So they need to understand that, and they need to understand what a dysfunctionality is. So it's almost inevitable that they will get exposed to, but you might as well expose them to a conversation, a heart-to-heart conversation, before they get exposed to it from a source that is not as healthy from the outside. That makes sense.
Well, tell you what, talk about knowing your audience. I mean, did I mention that Gretchen and I have a 7-year-old and a 1-year-old? But that's right on the cusp there, too. Man.
Yes. Yeah.
Thank you. And I think on behalf of more than myself there too, for everybody listening. Yeah. Oh man, that was actually a question I asked one of our previous guests. You obviously know him, Jake Nichols. And when we were actually chatting previously about the last time, I think the three of us were hanging out down by the Kanawha River in Charleston.
Yes.
After the WVPA, the state association meeting, or during it, I guess, the tail end of it at night, and campfire and making s'mores and all that. And same kiddo I was just talking about running around and having more s'mores with you, actually. But, you guys are both actually amazing authors. What propelled you to become an author? Like, what was it that you said, you woke up one day or a month and were like, I'm going to do this? What was it?
So I would say every now and then I would share snippets of my story, and everybody kept telling me, well, you need to write it down. You need to write it down. And then during the pandemic and the lockdown, I was like, you know what, I need a passion, or I need a hobby, because, the whole world is shut down. You know me, I'm a world traveler, right? So all my trips got suspended, and that was
about a change.
That was my worst nightmare. I wasn't able to travel. So I decided to sit down and just write. And boy, it has unlocked such a potential. And a lot of time I tell people writing is like, it's a form of art. It's a form of expression. It's a form of healing. I know in the mental health community, they really encourage journaling. Like, instead of like lash out in a journal and kind of write down how the individual kind of made you feel. And I will say in a way, it has been my go-to in terms of healing from my own trauma, from my own adversities. So it started off as a story, having a compelling story that people needed to learn more. And then that story led to the discovery of trauma, because when people read my story, they're like, well, there is a lot of trauma in your story, but you don't tell us enough about the mental health aspect of it on you. And that is what led to the journey of more books on trauma and vice versa.
Well, we're definitely going to include all that information in our episode notes here for everybody to be able to check out, of course, too. So, all right. So, one or two, I guess, closer wrapping up concepts here. Turns out this is the pain pod. There's like a question or two I ask everybody. All right. So, first one, how do you? And I think you touched on this a tiny bit earlier, but we'll elaborate here. How do you define pain?
Pain is life.
Well, that was succinct and awesome.
There is if there is no pain, there is no life. And it goes back to the whole concept of resilience. How much resilience do you have to cope with the pain, right?
Mm-hmm. Mm-hmm.
And that's partly why I always say that if I were to take anybody, because I'm a soul traveler, if I had an opportunity to cherry pick anybody to join me, I would pick a trauma victim. And I don't like to call it victim, so I would like to take that term back. I like to take someone who has experienced adversity in their life, because of this wisdom, because of this resilience, because of this growth that they've developed. Some people, unfortunately, are far more resilient than others to cope with pain. But I would say others are not as resilient. So to me, pain is it's inevitable. Pain is part of life. And that is partly why, and please don't feel like this is an indictment on you or Gretchen, because you guys are parents. I actually just posted this the other day about how members of my generation, the millennials, and I touched on the whole concept of universal participation or universal reward. Parents actually reward you regardless of winning or not winning a game. Well, that goes against the whole concept of pain, right? Like children need to go through that feeling of feeling like they didn't win. They need to experience adversity. They need to experience that there is uncertainty, because that's life, right?
Yeah.
But the more you prevent that as a parent, the more you limit them from experiencing what true life is, what real life is. Because let me tell you, they will fall one of those days. They will experience adversity. They will experience pain. And you teaching them the difficulty and the approach that it takes to get to where it needs to be, it's the only way of them getting to where they need to be. So you can't stop pain, you can't stop adversity, but what you can do is prepare them, give them the tools and resources to face the pain. So it is part of life. It's inevitable. It's going to happen. But it's all, how resilient are you to cope with the pain? Is it going to be through metacognition? Is it going to be through misusing or abusing substance? Because remember, it's not addiction, it's the pain, right? We need to redefine this whole concept of addiction. How do you cope with it? And this goes back to how you were prepared as an individual to face adversity. So pain is adversity in a way, if that makes sense.
Absolutely. And it's, like even in talking on the childhood part of it all, it's not the what, what success is, it's the how. It's emphasizing the how, even in successes of going over, hey, how did you do that?
Yes.
And then it's a lot easier in the conversation when it's a failure, because failure is part of success.
Yes.
I feel like we're at that campfire again here, but it's important stuff. So
no, it is.
All right. Now, this next question usually kind of falls right in place. I'm going to call myself out. I think it doesn't today, but I'm going to stick to the usual here and still ask of, because there's, pain being much bigger than just a medication, of course. But what would you say your favorite pain medication is? And of course, why?
Oh, gosh. I haven't tried all of them.
Most haven't. So
I'm going to be a little biased. Does it have to be pharmacological or can it be non-pharmacological?
You can do whatever.
I would say metacognition.
Okay.
Yeah, metacognition. It's been my go-to because it has been helping me a lot in regulating myself. As when I am regulated, when I am acting from my wisdom side of the brain, I am more reserved in a way, and I'm not as compulsive to the dopamine source. Is it food? Is it internet? Is it drugs? Is it TV? Whatever it is, metacognition has been helping me in a way to kind of keep myself regulated to any adversity. And there is a lot of adversity in the world. Everywhere. We're surrounded by it everywhere. So it is important to kind of keep ourselves regulated. So I would say my favorite go-to mechanism has been mindfulness and meditation first thing in the morning.
Well, thank you for that. And we got to have leeway there too. It doesn't always have to be medication. It's this isn't multiple choice final exams here or anything. So, oh boy. Well, Helen, thank you. Lots of great conversation and discussion here. Hopefully, our Pain Pod Nation here is enjoying things and listening in. We probably all left with some homework from listening to you today, Helen. So, just thinking through things. So, just really want to thank you again. And for everyone else, stay tuned for the next episode of the Pain Pod. But let's all take our homework here of really thinking through what Helen was saying to help all of us, not only in our own lives, but with our patients, our community, our family, our friends everywhere around the community. So thank you as always, everyone in Pain Pod Nation. Have a great day every day.
If you'd like to join Mark on the Pain Pod, send us an email to publisher at pharmacypodcast.com. And make sure to share the show and subscribe on your favorite podcast directory. Thanks for listening.